I'm here with Francis Ma, the chair of the ASCRS Cornea Clinical Committee. Francis, you gave a number of wonderful talks. Unfortunately, we're going to have to pare things down and talk about one.
Sure.
Now, this is a subject near and dear to my heart, as to all cataract surgeons, which is the use of intracameral antibiotics for cataract surgery. And let me just set you up with my own personal angst.
Absolutely.
Okay,
Absolutely.
which is that there's been this wonderful evidence. David Chang has been involved in a study with Aravind, more than a million patients, really showing a very strong case that intracamerals are of clinical benefit. Okay. On the other hand,
Sure.
I am concerned that if something unfortunate happens, independent of whether the intracameral had anything to do with it, that I'm going to be on the hook for it because there's no medication in the U.S. that's FDA approved for this use. It's still not, despite the evidence, it's still not standard of care.
Right.
You are going to, one way or another, put me out of my misery.
Yes.
So can I get you to
Hopefully.
flesh this out?
Yeah, sure. So, intracameral antibiotics, as you mentioned, very controversial area. The data looks almost incontrovertible. The fact that the intracameral antibiotic use does seem to be better than topical antibiotic use in terms of prophylaxing and preventing post-cataract surgery endophthalmitis. However, in the United States, unlike in Europe, we don't have an FDA-approved commercially available product for U.S. cataract surgeons to use, and so we're kind of caught in a bind. We know that intracameral antibiotics are supposed to prevent endophthalmitis better than topical. However, we don't have anything. We hear almost monthly about episodes of compounding pharmacies having issues with either infections that occur or toxicity that occurs. So we're kind of caught in a bind. Well, ASCRS has kind of heard the discussion. The executive committee, the governing board of ASCRS is initiating a research committee, and the first project for the research committee of ASCRS is actually to try to tackle this problem. So Doug Ree, who's the head of the research committee, along with the rest of the committee, have come up with a design as well as coming up with funding through the VA with a combination of VA, NIH, as well as the FDA, for essentially what would be a registration trial. So the study is called TIME, which stands for topical versus intracameral moxifloxacin for prevention of endophthalmitis. Again, we do have $50 million in funding to date. And as far as the size of the study, we're thinking about 74,000 patients, which need to be enrolled for the study to help prove that intracamerals are effective at preventing endophthalmitis. And again, this study could be used as a registration trial for intracameral antibiotics. And so in the very near future, ASCRS could have participated in getting an FDA-approved, commercially available intracameral product in the hands of U.S. cataract surgeons to really solve the conundrum that we're under as U.S. cataract surgeons in terms of doing the best thing for our patients and preventing surgery complications, devastating ones like infection.
Now, what is the planned duration for the study? Because I mean, obviously, you can't have findings till the study's over.
Sure. So that's an excellent question. So we do plan, and the FDA does allow for interim analysis of the data. Again, the study population is 74,000 patients. Right now, we're actually undergoing the site selection. So we've just had a conference call this past week regarding a survey for site selection, and we do want a generalizable population. We do want surgeons of all capabilities. Obviously, one of the main things is surgeons that have actually participated in clinical trials in the past. That makes it obviously a lot easier for for the ASCRS as well as the study to kind of get things rolling. We hope we can do this within a couple of years, but obviously it depends on how robust the data looks in terms of the ability for intracameral to prevent endophthalmitis and or how slow the enrollment is for the study.
Now, let me just parse things out a little bit here. We've conflated two things. Number one of them is the idea of an FDA-approved medication for, excuse me, let me be very careful with my words. An FDA-approved medication that we are using for intracamerals and a compounded medication that we're using for intracamerals because, of course, number one, as ophthalmologists, we're very used to using medications that are FDA-approved in an off-label way.
Sure.
And number two, of course, there is an FDA-approved medication that it is possible to use as an intracameral without compounding, which is to say the preservative-free moxifloxacin. So is a study like this needed?
Yeah, that's a great question. So as far as the moxifloxacin that's non-preserved, the Vigamox, it is FDA approved for topical use. It actually is not FDA approved for intracameral use. And if you actually look at the box or the bottle, it actually says not for use intracamerally. So for people that are using it, and I did use it for a while, it is again legally not supposed to be used. And so again, you'd be on the hook, as you mentioned earlier, if you had a problem. The compounding issue is an issue, but as you mentioned, we're very used to using compounded medications. Avastin, for example, is used, obviously many times over per day in a retinal surgeon's office for injections. Those are all compounded. Those are not FDA approved for intraocular use, and yet they're used over and over again. And we hardly ever hear of any problems with Avastin as far as compounding. As far as whether this is needed or not, you're right. There's two aims for this study. One is for U.S. surgeons who are contemplating or who are using intracameral to be reassured that intracameral antibiotics, in this case moxifloxacin, is the preferred way to prevent endophthalmitis. And then number two is for a company, if they wanted to use this as a registration trial to have a commercially available drug available, then this could be used as a registration trial. So there are two purposes. One is strictly for the members to feel comfortable and to have proof about the method that is best to prevent post-cataract surgery infections.
Well, for us all, and also for completely personal reasons, I wish you the best of luck, and I hope that the interim results justify our using this stuff very, very soon. Francis, I want to thank you, for this wonderful work that you're doing, that Doug Ree's doing, that the rest of the group's doing, and as always, for the generosity of the time that you've shown us today.
Great, thank you very much.